Hello, can you guys hear me okay? All right, sounds good. Well, sorry for running a couple of minutes behind. 2:25 is always really fun at this time. So my name is Noel, so I'm new to the VA, and I've been working at the VA since July. I was in private practice for about 3 years prior to coming onto the VA. This is my family. And my two kids, only one of them looks like me, but I assure you they're both mine. And so hopefully, like I said, being new, if I haven't met some of you, I probably will in the future, hopefully soon. So today we're going to talk about just phantom pain overall. So my interest in rehab is in amputations. For me specifically, I liked working with the amputee population because I felt that I was able to use a lot of my skill sets. So not only from a prosthetic fitting process standpoint, but also pain management, secondary musculoskeletal overuse injuries, back pain from alignment issues. You know, if they had a concurrent TBI from a traumatic amputation, as well as some of the new and exciting technologies on the horizon with amputee care. Additionally, with preventative secondary amputation, you know, I do feel that I'm able to provide a lot of education to patients and potentially make them more functional, like what we do with everything in rehab. So apparently I'm supposed to, you know, say this statement here. So there it is. And so phantom pain is defined as an unpleasant sensory and emotional experience. And I really like the fact that they added emotional component to the definition because it's very hard to measure. And there certainly is an emotional component. Sometimes it's hard to discern, you know, the etiologies or the contributing factors. And it's associated with actual or potential tissue damage or described in the terms as if such damage is occurring. And then phantom pain is defined as a pain experienced in a body part that has been removed. And so whether that's an amputation of the upper limb, lower limb, breasts after a mastectomy. So when we talk about how signals are propagated, I like the KISS method, keep it simple, sweetheart. So there is a signal. It goes to a peripheral nerve, which goes to a bundle of nerves, which goes to the spinal cord via the nerve roots, and then ultimately processed in the brain. Again, that's the keep it simple, sweetheart. You know, all the information that is perceived along the route from the signal all the way to the brain contribute to phantom pain and could potentially be an etiology for the phantom pain. And so the interesting piece is that it could be upregulated at any point of this cycle, and sometimes it's not so linear. It's very kind of circular and explosive even. And so just to keep that in mind. And the reason why I think sometimes phantom pain is so hard to figure out or treat is because there's so many players that can potentially be involved in which one's louder in the whole situation. So, you know, when it comes to the signal, the socket, which is the part of the prosthesis, please don't call it a bucket. This is the interface between the amputated limb and the external world. And so a proper fitting socket is absolutely essential before you can go any further with evaluation for phantom pain. And so, for instance, if someone has phantom pain and they didn't before, the first thing you should think of is, well, what's going on with your socket? Sometimes the socket's not fitting appropriately, and your only sign that it's not fitting appropriately is phantom pain. The suspension is really important as well. So for the few that have rotated through amputee clinic with me, there's, as you know, different ways to suspend a socket. is there's one with a pin, so there's a liner that goes onto the residual limb, and there is a pin that kind of clicks into the socket. And you can imagine that if you had some sort of spur or neuroma or bursa or something at the bottom here, and you also had a pin, well, this is kind of where all that contact is happening. And so if you examine clinically the residual limb where you're palpating and there's a lot of tenderness distally, you know, perhaps considering having the suspension change to something like a suction where it's the suspension is higher up and more diffuse along the residual limb. The soft tissues, I kind of alluded to some of that. So, for instance, is there a bursa? Is there a bone spur, bony prominence that's just pushing really hard on the soft tissues? Is there some sort of infection still lingering? You know, if the amputation was performed because of osteomyelitis, is there still some sort of residual infection in the bone there? So all those things we consider, especially with the socket fit. And so with the signal, things that we can do, TENS unit up here, you can rub the residual limb. This is what most people think physical therapy is sometimes. Applying cold or hot for modalities. Desensitizing techniques, rubbing it with different cloths. I do like contrast baths, if you guys are familiar or not familiar with that, but that's alternating between warm and cold, usually buckets of water. And not only does that desensitize the nerves, giving them something else to process, but it also creates a pumping phenomena. So when it's in a cold bucket, you get vasoconstriction, and then in a warm environment, vasodilation. So constriction, dilation, constriction, dilation. So you actually get some fresh blood pumping through the area. In terms of distraction, I do tell patients to utilize this, especially when we're trying to get patients off of opioids or other, change them from the acute post-surgical to sort of the chronic pain management. And so I do like, for instance, peppermint oil, biofreeze, icy hot. I talk to my patients about all of those. And then exercise. So, you know, as you guys may or may not be aware, there's different diameters of nerve fibers. And we'll talk a little bit more about that later in this PowerPoint, but basically the larger fibers tell our brain where our body is in space. So my hand's up, my hand's down, my eyes don't have to be open to tell you that. You know, when you're checking proprioception in the big toe, or is it up, is it down? Those are those large fibers. And they're myelinated. The C fibers are unmyelinated. Those are typically your pain fibers and autonomic fibers. And so if you have two signals that are traveling to the brain, it's kind of like dial-up versus cable. And I know I'm maybe dating myself. But so if you have a slower signal or a thinner wire, the signal's slower than if you have something that's insulated that can travel faster. So if they're trying to compete for acknowledgement in the brain, the one with the larger fiber that's faster is going to beat the smaller fiber. And so by exercising, you're basically, you know, racing and beating the unmyelinated pain fibers. So when you get a mosquito bite and it's really itchy and you scratch it and it feels so good, that's because you're activating your large fibers. And then you stop. And then that itch comes back because that C fiber has a chance to catch up. So sometimes distraction is really important. So as you saw from the first picture, I have two toddlers. And so if I don't give them something to do, this is a very common thing that can happen, that destruction occurs in my household. Versus if I give them something as simple as, you know, oh, can you put all the red cups in stack all the red cups and stack all the blue cups, all of a sudden they're busy and my walls are unscathed. And so when we talk about, you know, kind of the distraction technique, that's also part of it, giving them something to do so that they're not just sort of running amok. With the peripheral nerve, again, kind of going back to this sort of diagram, we'll try and follow that to keep it simple. I do evaluate for neuromas, which is not an uncommon condition after an amputation. Now, I know this talk is about phantom pain, and one of the things that's a little bit of a pet peeve of mine is that neuroma pain is not phantom pain, but it can contribute to phantom pain. And so, I'll talk a lot about kind of sometime in the next several slides, whenever, about neuroma pain, but it's not synonymous with phantom pain. But it can contribute, and I hope to explain to you how. So neuroma is a growth or an enlargement of the tumor, or a tumor of the nerve tissues, and they do have several C fibers which have mechanical receptors within the neuroma. The other thing to consider is that, especially in amputees, there's a lot of compressive neuropathies. So just like we were talking about the socket, based on where those trim lines are or where the socket ends, sometimes there can be some compression. So for instance, I just had a patient last week who is an above knee amputation, and he was having a whole bunch of pain on the outside of his thigh. And it's not uncommon also to get some weak muscles, get a Trendelenburg gait when you have an above knee amputation. So he was being treated for IT band, when really he had a lateral femoral cutaneous nerve of the thigh impingement from the high trim line. And so we went ahead and blocked it. Had a really great response to that. There it is. Kind of keep the drawing modest here. So when we evaluate this via ultrasound, you palpate the ASIS, and you go about 3 finger breadths inferiorly and go slightly medially, and that's where that lateral femoral cutaneous nerve of the thigh is located. So from an imaging standpoint, it's located just above sartorius, and that's it right there. I do often, actually I do quite often, sciatic nerve blocks in the amputee clinic for phantom pain or chronic amputee pain. And so I do it distally. And so there's a couple of techniques, but if you think about someone who is a above knee amputation, sometimes you can't you can't go to that popliteal fossa and say, oh, okay, let's walk up. The other thing is depending on the surgeon, you don't know how high up that sciatic nerve is buried. And so I'll often start kind of in the middle of the thigh. The sciatic nerve is located between the hamstring groups. And so I just know kind of anatomically where I'm going. I place it there and I just scan. And I look for the nerve. And then I follow that as distally as possible. If there is can you see my arrow? If there's like a ballooning or whatnot, I myself don't feel comfortable diagnosing neuromas via ultrasound. But, certainly after doing them frequently, you can kind of say, oh, that looks a little big. And maybe prompts further investigation. And this is just showing that sciatic nerve between the so the peroneal nerve at the fibular head is also a common compressive neuropathy with the socket, and so typically, this is also where a lot of your EMG skills come in. You know where the nerves are because you know where you're stimulating, and the course of how the nerve travels. And so, the picture to the right of you guys, yeah, left of you guys shows the common peroneal nerve at the fibular head there. So that little mountain. Can you guys appreciate that? Because my arrows don't really work here. But the mountain there is the fibular head, and there is the nerve. And so we go ahead and block that often as well. And so and now I'm going to apologize because you're going to see how bad of an artist I am. I did this on paint. So if this is a nerve, it is filled with several neurofilaments within the nerve. And so when the nerve is cut, sometimes a neuroma forms. And so a neuroma is sort of like this disorganized jumble. Oh, thank you. So fancy. There it is. So in case you couldn't tell from my drawing, that is where the neuroma is. So disorganized, jumbled set of neurofilaments within the terminal nerve there. And so, so when we were talking about the diameter of the different nerves, again, you know, the larger fibers are telling us where our body is in space, and then as you lose myelin, they get smaller in diameter, and this is kind of where more of the pain and sympathetics kick in. And so those neuromas do have those mechanoreceptors, and so if you were to apply a certain force down on the nerve where it's unscathed, that activates 4 neurofilaments. And so if you were to go ahead and apply that same force to the neuroma, instead you kind of maybe get 8 or 9 neurofilaments activated with the same stimulus. That's why you kind of get a little bit more of a, oh, it just feels a little bit more information. So there is a approach called targeted muscle reinnervation. Has anyone heard of it? So targeted muscle reinnervation was actually designed to use the muscles as myoelectric controls for high upper limb amputees. And so what they did is they would take the different nerves of the brachial plexus and typically, so let's just say it's for a shoulder, they would bury those inside the chest wall at different sections. And so whenever you wanted to flex your bicep, well, the musculocutaneous nerve innervates this part of the chest wall. And so the nerve that normally flexes the bicep is what's actually twitching as your switch for the prosthesis. And then say you wanted to close your hand. Well, the ulnar nerve is innervated in a different part of the pectoralis. And so when that switches or twitches, it activates the electrode in the socket and causes the prosthesis to have that response. So it is a very intuitive surgical design. And again, it was made or invented specifically for use of myoelectric controls. And so incidentally, we've accidentally found out that it's also really good for neuroma pain. So in this very small study, which has prompted a larger study to be done in Chicago, 15 of the 26 patients had neuroma pain before TMR, retrospective. And then after the TMR, 14 of them had complete resolution of the neuroma pain. So what defines a neuroma? Clinically, you tap on it, it gives you a little buzz that's called a tunnel. And so, you know, when patients are being evaluated for TMR, and I had one today, if you're tapping and you don't get a tunnel or you don't have an actual radiographic, you know, via MRI or whatever, confirmation of a tunnel, you know, typically and they say that, oh, gosh, I have all this pain, all this neuropathic pain, this may not be as very beneficial for that individual. I will say that I have 3 patients that had targeted muscle reinnervation in the lower limb, and anecdotally, I'm not getting the same results from a neuroma pain standpoint. So I do think that it does require further research to really have a talk about this when we use it formally as a pain intervention. And then what TMR is so, let's see if I can get this. Right there is the neuroma, and so what the surgeon, usually a plastic surgeon, does is dissect out the 2 branches, and what they do is they connect it to the motor points of the branches that innervate the so they do a nerve-to-nerve anastomosis, and even though, you know, for me, I was like, well, that's a big nerve, and that's a small nerve. But interestingly, it actually takes pretty well. And the chance of having a new low, the thought process is that when, you know, the don't get that jumbled appearance, you get a little bit more of a uniform distribution of the nerve. Kind of moving up that signal peripheral nerve, spinal cord region pathway, it's important to talk about the dorsal root ganglion whenever we talk about chronic pain. And so the dorsal root ganglion is really interesting because it has a bipolar type nerve that allows propagation for a signal to either occur or cessation of it. One thing that I'm very interested in general is the sympathetics and how that plays a role in overall chronic pain. And you can see kind of the sympathetic chain being really close to that dorsal root ganglion. So when we look at that dorsal root ganglion and kind of what happens, and I apologize if this is too much like kind of basic science for 5:30 in the afternoon or whatnot, but the, so here you have your C fibers coming up, and they kind of have their own pathway, and you have your larger myelinated fibers having their own pathway. And so there is some sort of upregulation of that C fiber, or the signal gets intensified or maximized. And so the sympathetics actually play a role in this occurring. And so by this input, there's actually a sort of for lack of better terms, a burnout. And there's this the compensation where the A beta fibers kind of cross over. And so this way, when this guy gets stimulated, it's kind of sometimes perceived as thyroid. Am I explaining that okay? Is that and so then what happens is then you kind of lose this normal input of what is a C fiber or nociceptive pain. And so, and that's, something that we'll come back to. But when I think of medications for nerve pain, this is the diagram I think of. So, you have your dorsal root ganglion here. Here's your C fiber. Here is your A delta fibers. This is the spinal cord, and then there's a signal that goes to the brain way up here, and then it comes down to send a signal back to the tissues. So, when I talk to patients and we say, let's start with gabapentin. Well, if you look at kind of where all the receptors of gabapentin lie, there's quite a bit of receptors to hit there. So, that's usually a very good drug to start off with. For me, my next line is usually a tricyclic for phantom pain, neuropathic pain. And then depending on, how much I think there is in terms of a component, I have a low threshold also for, doing something like an SNRI. Interestingly, one of the receptors that I kind of like to learn a little bit, or a little bit more interested in, is the NMDA receptor. So the NMDA receptor, if they're active now, it means you're actually committing memories, which is great. And so, a lot of European research actually, or a lot of European protocols pre-amputation give patients dextromethorphan or cough syrup because it blocks the NMDA channels, which potentially can block that long-term potentiation or the memory of the spinal, that occurs in the spinal cord. Tricyclic antidepressants are a weak NMDA receptor blocker as well. So, kind of going back to this slide, the C fibers, or the normal C fiber pathway here, is responsible for maintaining the somatosensory cortex in the brain. So that's that homunculus picture as such. And so using magnetoencephalograms, we're able to show that when you lose a hand, the representation of the cortex for the hand kind of diminishes, and the ones that are adjacent kind of grow. So if we were to reorganize homunculus's space, kind of gets pretty big. And, some studies in the 80s show that with upper limb amputees, you can sometimes spark phantom pain just by touching their face. And similarly speaking, it's not uncommon that patients with lower limb amputations, when they do have phantom pain, one of the most common triggering factors is And for females, their menstrual cycle can also be a factor. And so if you noticed in the homunculus next to the foot is the genitals. There's some reorganization of that somatosensory cortex, which we know is pretty pivotal for phantom pain from a reorganization, brain. Has anyone heard of telescoping of the limb? This is where you feel like the phantom limb is actually shrinking. And that actually corresponds very well to the neuroplasticity or the dying back and reorganization of the somatosensory cortex. So if you have telescoping phenomena of the phantom limb, that's actually correlated with a higher risk for longer phantom pain problems. So, sorry, half the slide disappeared. But this was a, have you guys heard of mirror therapy? This is where you have a patient who has a sound limb and an amputated limb. And you put them in this box where the mirror, you're kind of, it looks like visually you have two limbs or two full limbs. And then you have them do exercises like think about bringing your feet up and down. And so this paper was published in the New England Journal of Medicine where they used not only just sort of mental visualization, but also mirror therapy. So there's something about not just mentally thinking about it, but your eyes seeing it to give feedback to that somatosensory cortex. And so as you can see from the graph here, this was a crossover study, and they covered the mirror just to make sure that that mirror didn't have very special powers otherwise. The mirror therapy group did very well, such that they did a crossover, and once that crossover occurred, the non-treatment group actually responded very well also to the mirror therapy. I will say from experience, vets get a little, vets and patients, both in my private practice that I had as well as currently, after an amputation. So being sensitive to how that might be re-traumatic. Talk about traumatic. There's this little structure in the brain called the amygdala. And this is actually a primitive fear center in the brain. And interestingly, your actually has direct access to that amygdala. And so that's why if there's something that's very emotionally charging, such as this lecture, you're more likely to form it as a long-term memory because your hippocampal region as well as your the amygdala also has direct communication with your aesthetics. And so sometimes there is a sympathetic response before you even are aware of it. Things like cognitive behavioral therapy, EMDR, pain response. Interesting. Also responsible for and so, phantom pain is not something small. It was so hard to make a talk about this because I could write it. I would want to write a textbook about it. There's a lot more to this. There's things like glial cells, which were thought to be sort of support structures. Glial meaning glue, and I think Greek or Latin. And so we're finding that the glial cells actually have a significant effect on upregulation of a signal. So there is current basic research going on about how to block glial cells. Another area of interest in terms of neuropathic pain is cytokine release. And so the cytokine release being able to upregulate a signal anywhere along that pathway or downregulate. And so they're trying to actually make these synthetic cytokines for such response. And then, in terms of, it is a big area of research. And so there's a lot of things on the horizon. I myself don't do any axial interventions, but there's spinal cord stimulation. There's important to go from sort of least, kind of go up the chain. And so, these are just some non-surgical, non-medication interventions that you can do for phantom. The shrinker socks is like a compression socks to reduce the swelling and whatnot after an amputation. And, I do always say beware of the bias in the literature because phantom pain is actually, there's a lot on it. However, the control is not good or great because, like I said, there's so many factors that interplay with phantom pain. And then additionally, majority of the research in amputees in terms of phantom pain is conducted on traumatic amputations and not our diabetic vasculopaths. And so just a personal anecdote from myself, being in private practice, I was doing a lot with work comp amputations. And so I had sort of this unique population that was, I would say about 90% of my amputees were young and athletic. And we were talking about how to get back to marathons and 14ers and all these, high activity levels of function. And so, when I come to the VA, I'm asking all of my patients, tell me about your phantom pain. They're like, I don't have that anymore. And I was like, oh, okay, because in practice, everyone had phantom pain. So, it's hard. I think it's important to make sure we sort out the etiology. Is it traumatic? Is it vascular? Is it infectious? Is it cancer from sepsis? And perhaps, if there's a traumatic event, there's a lot more sympathetic response. And so maybe a lot more heightened and so that, as you like to hear at the last lecture of the day, we do you guys have any questions at all, or? No, they removed the disc, so they cut the neuroma. The remaining are re-anastomosed to the motor points. Yeah. I can tell you, and I'm obviously not a surgeon, but there's a lot of different surgical research going into neuromas. Wrap the nerve when they cut it at the time with amnion, neuroma formation. Some surgeons would like a thin layer of muscle and kind of wrap it up into the nerve because for whatever reason, muscle is not only a good sort of soft tissue coverage, but it's a little less likely to form a neuroma if it's around muscle. So there's something about that motor piece that I don't understand from a basic science level. Some surgeons, like I was saying, you don't know exactly where in the thigh it is, will kind of take it and bury it deep. So if a neuroma does form, they're hopeful that a lot of that soft tissue coverage can provide some cushion and padding so it's not irritated so much.